As mentioned earlier, this is the third series of the gynae Hibina series, focusing on gynae outpatient. For this time, we decided to make it free for all participants because of, I think, this is as a part of our commitment in joining the global effort in especially talking about Malaysia, in order to eliminate cervical cancer by 2030. My focus today will be on role of primary care, which is actually, as we go along, we discuss and agree actually that the majority or the bulk of management and the bigger role in eliminating cervical cancer actually rely on the primary care services. So, um, as an introduction, cervical cancer, I hope that actually, I always talk to my students. Hopefully, in the coming 10 years or 15 years, we are not going to teach very much in detail about cervical carcinoma or cervical cancer anymore. Like us, for now, we are not talking about smallpox. We don't learn about smallpox anymore because it had been eradicated from the world. So we are hoping that cervical cancer is going to be the first cancer to be eliminated. So, we are not going to teach in detail about cervical cancer maybe in the next 10 or 15 years, hopefully. Okay. So as for now, it is still the fourth most common cancer among women worldwide, and it affects about 12.9% of among female cancers. Cervical cancer comprise of 12.9% of all the cancers, and globally, actually, in 2020, it affect about 600,000, more than 600,000 new cases, and cost 342,000 deaths. So as you see, the problem of cervical cancer actually rely on the high mortality. If we are not talking about morbidity. Even in morbidity, the problem is even higher. Okay, because cervical cancer is a debilitating disease, even though it's advanced locally, tapi it's a very debilitating disease, causing many problems. Okay, that's another important reason that actually we need to be serious in managing or reducing the cervical cancer occurrence in the future. So 90% of the death and the problem actually occur in low and middle income countries, in which the screening program is not very effective and the vaccination is not really covered. So another important aspect in cervical cancer actually is the peak incident actually occur at the peak, at the height of a woman's what we call that, uh, um, golden peak actually. Okay, golden means at the age, at the peak of the reproductive age. This is the age of 45 to 50. This is the age that usually now we are talking about success, women in their success career, in the important time of bringing up children. Okay, this is the time. All right. So that's another reason actually cervical cancer need to be taken seriously, because it occur or it causing problem in the not to say very young, in at the peak. Actually, this is a golden time actually for a woman about 40 to 50 years old. So you imagine, you are at the age, or you are at the period of success in the career. You are in the period of talking about family. This is the period of the children anak tengah sekolah, right? This is the time, a very important time of a woman. So that's why cervical cancer need to be taken seriously. Okay, so we know from this is established facts already. It's not based on just assumption that cervical cancer is because, or it is caused by persistent HPV virus infection. So it is noted that almost 100%, actually 99.7% or up to even few studies, 10.9% of cervical cancers actually due to HPV viruses, human papilloma virus, right? And among the virus, HPV 16 and 18 attribute to 70% of cases. So that's why if you see at the in our screening, in our HPV test later on, we will see, and also in our vaccine, we are concentrating on HPV 16 and 18 because this occur in majority. But nowadays, actually, the other high risk HPV strain are also important, especially in our region in Malaysia. Okay, we are not. There are some variation in certain regions in Malaysia. Actually, not the 16 and 18 causing problem. There may be others like 58 or 52. Sorry. Um, so among risk factors, all right, of cervical cancer actually is previous CIN, smoking, immunodeficiency like HIV, any immunodeficient drugs, and actually, if you are talking about in clinical setting, in reality, the highest risk factors, I will come into it later on. I will highlight it and emphasize it later, that the highest or the biggest, most significant risk factor for cervical cancer actually not being screened means a woman not in the cervical screening program. Okay, never had not HPV DNA test, or never had Pap smear. Actually, those women actually the highest risk factor. All right. Um, okay. Why we are talking about eliminating cervical cancer? Actually, back even in 2018, WHO DG at that time had made a call of action, all right, for all countries in the world to help ending the suffering caused by cervical cancer. Okay, so then later, many discussions and meetings lead to the development of global strategy to eliminate cervical cancer as a public health problem. So it's not just talking about preventing cervical cancer. It also in the strategy also focusing on how we can reduce, or how we can move or remove cervical cancer as a public health problem worldwide. Okay. So another important landmark actually is our introduction, not to say introduction, our change from Pap smear as cervical screening, primary cervical screening, to HPV DNA test. So back even in 2020, this we call swab. So this swap had entered a parliament when Deputy Minister of Health at that time actually explaining about the HPV DNA test, self test, replacing Pap smear, in stages lah. Of course, if those you are in KK, it started in few states, and actually original plan by 2023, if I'm not mistaken. It will be across the country, but of course, we know COVID-19 struck, and everything. Not to say everything, many things had been postponed. So, okay, I mentioned earlier, and these slides or this diagram actually will be repeated again and again in my slides, just as a reminder and as we go along. This is the global strategy that I mentioned earlier, that been introduced by WHO. The global strategy comprised of a few points, or we call it architecture. But the aim, we need to, the vision actually is the world without cervical cancer. So the calculation, or the threshold actually is for all countries to reach less than 4 new cases per 100,000 woman years by 2030. So and it had been introduced into the SDG, the extension of the MDG. So SDG 2030 is the target is to reduce the mortality from cervical cancer by 30%. So that's another aim in which if we reach the target of less than 4 cases per 100,000, we will reach this 30% reduction in mortality from cervical cancer. So how is the architecture? Okay, so this is important to remember the 90-70-90 architecture. So in which the first arm or the first aspect is reaching 90% of girls fully vaccinated by the age of 15. The second pillar of the architecture is 70% of women managed to be screened with a high precision test. So the key point is high precision test, and as we know now, for current for talking about now is the test is HPV DNA test. So in WHO target actually at least women get screened twice at the age of 35 and 45 years. The third pillar actually is the management, in which 90% of women identified with cervical disease receive treatment and appropriate care. So if you see at the 90, 70, 90, as I mentioned earlier, why the primary care is very important, at least these two, first and second pillar is directly related to primary care services. And also in the third pillar, maybe part of it is contributed by the primary care, in which if you cannot identify, we cannot have a proper referral mechanism, for example, then we cannot achieve this 90%. So yeah, this is another slide just to illustrate more about the 90, 70, and 90 pillars or architecture. And we will go through, even though the first pillar is vaccination, but we'll go to cervical screening first. And later on, we will talk about vaccination and what's happening now in Malaysia.